Okay, cool. Let's go back over here. Oh, hey, come on over. Did everybody get a chance to sign in? All right. Let's see. Load this up just a hair. So you guys can see it in the back. And then I need to, let's do this. Share screen. Cool. Well, how's it going so far? All right, well, I thought we'd take a couple minutes and we do some brainstorming and see what's helpful, what's not been helpful. And just kind of have an opportunity to sort of check in, does that make sense? And so we can see how we can best support you all and we want to see you succeed. So, talk to me, how did this last exam go? They like, you got it. Like, that was like awful, right? Was like, I don't know, so everybody, worse than expected, okay.
For me, it was like the medications, the drugs itself, I couldn't relate to each. The disorder, disorder.
Okay,
Yes, relating.
relating the
I feel like
drugs
it's too
to,
Names and the names are weird by itself, themselves, because, relating it
to like an illness or something.
to.
Would that be more helpful to have I've often thought it would be interesting, like when I was sitting in Phram, where you guys were last year, I'm like, I wonder if it'd be helpful to like have like your disorder of the day, and like, oh, it's like a kidney patient. So like, okay, then we'll talk about kidney drugs, but like, let's try to tie it to a patient or something like that, but I don't know if that'd be helpful. Yeah. I don't know, what are some strategies that might be helpful? Because this is new to me. I've never tutored Phram. I survived it, but I didn't tutor, right? So it's a little bit different. And this is new for Professor Bays too. She's not taught it before, but she's a good instructor, but this is a new course for her as well. So the other person you can reach out to as well is that you can, as far as tutors go, we have other tutors and so know that. And so like, if you're like, hey, you're trying to get on my schedule, can't, nothing's working, or you just like, hey, I need more help than what Ben or Professor Bays can provide, that's okay. We have other tutors. And one of them is Bree, and Bree graduated just now. So she just finished, but she's rolling right into the nurse practitioner program. So she's pretty smart. So she's another person that could be a really good resource for you. And so are Brittany, Ari, and Sarah, those are my classmates that are my cohort. So we feel your pain. We struggled with Phram ecology too, to some extent. And so I think it's part of it, it's the topic, but I also think part of it is the strategies that we employ to try to learn it too. And so one of the things that could be really helpful, at least for what I found helpful, was to do the key points from your chapter. Did you guys all see the little video that I put together for you on how to get those out of your chapter? Okay, so I did email that out. And if you might not have gotten it, I don't have everybody's email. I don't go through Blackboard because I'm not a part of, I'm not officially a part of your class, so I don't see whatever you guys see on Blackboard. That's why I sometimes will ask Tristan or others and say, hey, can you email me the most recent version of Bayes, presentation in case you made some changes right before class, because I don't have access to that. So, but if you've come and you've written that in your name, I've been trying, or if you've emailed me for tutoring, I tried to keep adding you to a list, and then it just keeps sending out those resources. But it's a quick little 5-minute video, and I can show you after class or after we're done here at some time. When you bought your book, either electronic or in person, there's a scratch off. And then there's like an electronic version of your scratch off too. And I can show you how to get to that. And that'll give you key points, which will give you basically a chapter summary. And so it's helpful to look at your chapter before you go to your lecture on that topic. And so I really want to encourage you guys that, because right now pharmacology is totally brand new for all of you. And it was for all of us, right? We've never had a class in pharm unless you've been like a farm tech or something. And so the key points are just like it's somebody, the publisher went through and summarized what's important in a chapter. So you're like, well, that's awesome. So you can print out a copy of that and maybe, or look at it on your screen, and it just kind of, it's a regular document, like a rich text format. So, and then you can just make some notes, read that through before you go to your, the lecture that she's going to be lecturing on these drugs. And the reason for that is the idea of creating folders in your brain. Does that make sense? So the first time you get exposed to something, you're like, what? And so you want to have that what deer in a headlight look. You want to have that like on Tuesday or Wednesday when you look at this for the first time and go, what? And then read about it a little bit. Maybe watch a video from like Simple Nursing, just Google anticholinergics or epileptic drugs, and you still might be like, what? But then you go to lecture, and as Baze is talking, you're starting to make those connections. And that's what pharmacology is. It's a lot of making connections. And I think you're all really smart. And I know that, or you wouldn't be in this program. So you had to outcompete other people in your program. You had to have at least you have to be at least B students to be here, at least a 3.0 or better. Some of you have 4.0 students in your prereqs and stuff like that. Some of you are probably 4.0 students in college or high school. And so, I get that. I was a smart person too, and farm kicked my butt. And that's because, and it did for a lot of us, because we are used to, if you're smart, along. And I know this because you're here. You can fake a lot of your classes. Don't tell me it's not true. You can phone it in. You can show up on an exam because you sat in class and you probably can remember enough to like BS an exam and do okay. Or maybe a study for a couple of and some of you are in that boat. You can admit it. You are. You can't do that with pharmacology. It's too much memorization. And it's too new to you. You can there'll be classes you can do that in nursing school, but pharmacology is not one. So that's one. It's like, okay, you gotta focus on that. Assessments is a lot like just learning your lines and fundamental. If you've ever been acting, ever done any community acting, it'll be what's the role? What role? Oh, I'm supposed to, this is my line. I come in. Hi, Mr. Jones. I'm going to assess you from your head to your toe, right? And you're just doing the motions, and you're like, that's all acting, and you can totally act that, but you can't act farm. You can't just show up and kind of BS your computer exam. It'll kill you. And the way that Baze sometimes writes questions and Heinzelman writes questions, they'll catch it. I mean, it's just the way it is. So some study strategies that I would encourage is the key points, or at least looking through your textbook. And for every chapter before your particular exam. So here's the one on, here's like an anti-inflammatory. This is the previous version, but not all pretty much the same. Here's anti-seizure drugs. So one of the things that's really helpful is to take a look at the objectives, and then just kind of scoot through. And you can do this for all your textbooks. I don't always, but it's a good idea to consider. Take a look at the outline, and then take a look at anything that's English-based especially, or if there are terms. Just doing a couple of test reviews for Professor Bazak. And one of the things that I was seeing was some consistency in people having problems with the question because they forgot the difference between cholinergic and anticholinergic, or they didn't know the difference, or forgot the difference. We might have known it, but test anxiety predicting between like agonist and antagonist. And so you like try to, if there's a new word in there, try to get it really stuck in your head. So we get that all the time. But this is pretty basic kind of stuff. But then I would say take a look at the key points. I provided one for there's the Alzheimer's and Parkinson's meds. But I'll show you and put the video on how you can download it. And then just kind of take a look at it. You don't have to memorize this stuff at all that's in here. And then just kind of glance at it before your lecture. And then at the end of each chapter, there are questions. Simple questions. There's also back in the tutor thing there. There's this book here, which are all sample questions that you guys can utilize on the topics for out of the textbook. Then if you have access to Quizlet, there's a bunch of sample questions on there as well. And so you can kind of just sort of start getting those sample questions. And that's another challenge with Phram and the first part of nursing school is NCLEX questions are weird. Like if you were taking a look at some of those questions, it's like, okay, so you expect that you know a little bit about this medication, and then they're going to apply it in this way, and then you got the patient that presents with this. Can you give that? Right? I mean, that's not some of the question. That's a pretty complicated question, and a lot of that comes from you'll learn to love her name or hate it, whenever. But her name is Patricia Brenner. You'll hear this name often. And she has this idea that you move from novice, which is like, I don't know nothing, to expert through your nursing career. And so if you ever take a look at your syllabus and you see like N, because you're seeing like this little chart that says N, eventually you'll see novice and you'll start moving to like competent. And then you're like, oh, okay. So hopefully when you graduate nursing school, you're competent in all these different things. That's the philosophy of the CSU nursing programs, all based on Benner's philosophy. So they're looking at that, and they're looking at what's also called Bloom's taxonomy of learning. You don't have to remember all that crap, but that's just a way of saying there are different levels and different ways of information. The first is regurgitation, and that's the easiest way to do school. And most of our undergraduate classes, career nursing and like high school, those are regurgitation. You're like, how many planets are there? Well, 8, 9, I don't know. How many are there? Say it's for Pluto, right? Mm-hmm. But that's a regurg, that's capped. And then, but Bloom's taxonomy of learning and nursing processes to be able to apply that information. Because it's great to know that if you're on Jeopardy, that there's 8 planets or 9 planets. We got the day. But it doesn't help you at all if you're seeing a patient who can't breathe. You need to think to yourself, what the hell is going on with my patient, right? My patient is dying in front of me. He's not looking very good. I can call a rapid, but at some point I need to be the one who's responding to the rapid and knowing what's going on. And so that's application learning. So that's a little bit of that. So sorry, that was a little too deep, but I just thought I think some of it might be struggling with some study skills. And some of it might be learning the content as well, and then also testing strategies. So there are like three sort of like think like a stool that's got 3 pieces. So like if I can help you with those testing strategies, some study strategies, and then the content that should help you out. And so we talk a little bit about the study strategies. And if you have questions on that, that's where tutoring comes in. Like, and so same with the testing strategies. How many of you watched Beige put together a video for you guys on how to do, like how to take tests? A couple of people. Was it really helpful? Yeah. It's a little bit helpful. There's another book that you guys have, your NCLEX comprehensive book. It's like bad, or maybe if you got it on an electronic version, it won't be so bad. But There's that book and there's a little skinny one. Those books are all about how to hack NCLEX style questions. The skinny one is just all strategies. It's worth your, it's worth some time reading. The first part of the comprehensive book is all on strategies, and then there is a chapter on each of the drugs, like section. So you're gonna right now looking at CNS drugs. We grab that book. Dinosaurs. That makes it that. So this is the test taking strategy, but like it's literally how to game the NCLEX. Don't be like my wife who didn't realize she had these books. She had to buy them in a bundle and started reading them her last semester. She totally did that. And she's like, oh, it could have been so helpful. This teaches you about every single kind of question that there is. And then what to look for in the question. Okay, so gold. And then this is pretty much the same. The first part of it's going to be more preparation and strategies and for like professional standards. So this is going to be your professional standards. This is your class that you're taking with ethics and stuff like that. Then you have OB, fraternity. You also have like growth and development stuff in here, foundations of care. You guys take fundamentals in here. Well, a bunch of fundamentals questions. Some of those questions that you're taking in your fundamentals might actually be coming from this book. By the way, just let you know that. Maternity. Pencilman does pull questions from this book. You know the electronic version is not all of them questions come from that, but Peds, Phram has been known to pull questions from this book. Why? This is actually your textbook from the term. Einzelman likes it so much that you can buy the book from Loudermilk, but it's optional. Just like use this one. And then if you take a look at like adult, here's like adult oncology. And then it's a short little chapter. On this, it's maybe 10 pages on, and so this is a good thing to review before you have that lecture with days. And you flip over to here, and then you have these are questions, and you see all this. These are all the rationale and strategies on how did you get through this. This is why I'm saying this book is helpful because it's like okay, so I got that question wrong. Well, why did I get it wrong? Well, I got it right. Well, why did I get it right? What should I be looking for? And they're like, hey, you see how this question is written? Like, that's how you should consider that. So that's helpful. But look at that. These are your cancer meds that you should know. And that's it. 2 pages. I mean, there may be a few more, but like that base wants you to know that it's not very long, right? And then some test questions on this. And these are resources for you. So endocrine, and then endocrine medications. And so we'll take a look, you can also take a look at like CNS medications and antidepressants and things like that. Information will be helpful for you. So I wanted to let you just like, there's a lot of resources out there. I know it can feel like just like overwhelming. Yeah, you know, it's like, or a lot of it. It's like drinking water from a fire hose. But is that helpful to know that those are there? Maybe take a look at that. I did a review last Wednesday and we looked at Alzheimer's and Parkinson's medications. I emailed out that week. This one's being recorded too, so we can share this one as well. So you guys can have that and go back and look. So we addressed a little bit of that. What would be most helpful? So do you want to look over the stuff from Friday? Or yeah, okay. That'd be helpful. All right, now let's do that. So what's a seizure? Say that one more time louder.
A dysregulation of
You just one of 10. you go. That was a really good definition. Yeah, it's basically your brain's like, what the hell? And it starts firing. They think it could be a lot because it problems with like the sodium channels in your brain or something like that, which is why a number of the medications that are used for your brain for anti-epileptics have to do with sodium channel. So there you go. But there are a couple different kinds. There's the partial, which is a focal seizure. So that's going to be like a focus area in your brain, as opposed to all over your body, or a focused area in your body, not all over your body. Then you have the tonic-clonic seizures, which is what they're being called these days, as opposed to grand mal seizures. I had a friend of mine who was diabetic and he had those. So sort of freaked me out. He was in a parking lot like, I was in high school. Didn't know what was going on. It turned out fine, but it's low blood sugar. We were on the way to get him something to eat, and that's what happened in the parking lot. So then you have absent seizures. I think I have absent seizures all the time because my wife looks at me and I'm not like paying attention to her. It could be that, it could be ADD, I don't know. But I have this blank look on my face and she's like, Ben, hey, are you here? Oh yeah, okay. So that's an absent seizure. I'm not around. So some different causes are going to be things like TBI, West Nile, meningitis, basically stuff that causes inflammation or swelling or something in the brain. Some kind of damage or something to the brain. So phenytonin is best for a partial clonic, or partial or tonic clonic, and valproic acid is effective for all. I don't know. These are from her notes. And so when it comes to some of this stuff, I don't know what's important or not because I don't write the test, right? So I can't say, hey, so some of this is just a little bit of a review. I realize I'm blocking that. So is it okay if I sneak here? Okay. You guys can see. All right. I forgot my remote mouse. So this is important. I think there might be a question on this one. I don't know, but most anti-epileptic drugs, they have a narrow therapeutic window. And that means what happens when do you remember what the therapeutic window is from your first exam? Yeah. Okay, so one more time, you're there.
Okay, so it's like. It's like, so there, it's only like a small amount that could take it over toxicity or something.
Yeah. So with that, and very good. Do you want to what's that other one?
And you administer the drug, there are different dosages.
Uh-huh.
And this kind of dosage, like this amount will give you the effect. Then like if you give more, there's toxicity. So there's an overlap and like
Yeah.
between them, that's the amount. If it's short, it could be potentially dangerous because you give a little bit more or the body keeps up a little bit more of that drug and then it causes toxicity.
Good job. Yeah. So the difference between get some more. Use your resources and services. Yeah. It could be each other. So it's a narrow therapeutic range, which means that the therapeutic level and the toxic level are pretty close together. And so I have to get this amount in order to get a therapeutic benefit. But if I get a little bit more, it could be deadly. Does that make sense? That's small. But like vitamin C, yeah, I can take 4 grams of vitamin C and it's not going to do anything. But if I took 4 grams of like fentanyl, I'd be dead. And so everybody like downstream of my urine, which I both get tens. So there you go. So good. So that's that. So that might be something to be aware of. And you don't want to stop cold turkey. What would happen if I stopped a medication that helps stabilize my neurons? It's cold turkey. Yeah, totally. Status epilepticus. There's a pen for you. I only got 8 of them from the box, so there you go. So another of them are teratogenic. Teratogenic. Anybody watch like Agents of Shield? Okay, now I'm aging myself. Damn. And that's not bad. Okay, so they're I won't go into it, but something that's teratogenic means that it causes birth defects. Okay, and it also decreases the effectiveness of birth control. And so this will probably be a test question here. You want to teach them to use an additional form of birth control, an ideal, like, so if they're on pills, you probably also want to teach them to either get an IUD or like a barrier, because it's going to decrease the effectiveness of birth control, but also increase the effective or the likelihood of like birth defects. So you know, that's a good teaching thing. And if they miss a dose, tell them to take it when they remember, and then they can resume it unless it's the next day, and then they probably shouldn't take 2 doses on the same day. There's a couple of different types of medications, and we'll get through these in a minute. But just as a reminder, enzymes often break down drugs. So an example is acetylcholine esterase, right? And you got that ending AS. And that means it's an enzyme. And so that's going to take down or break down the acetylcholine esterase. So it's going to break down acetylcholine. And so if I take acetylcholine esterase or a drug that blocks an acetylcholine esterase inhibitor, that's usually what we see. Or also, you'll see this on here, a monoamine oxidase inhibitor, right? That's also going to be in your exam. For a monoamine oxidase inhibitor, like B inhibitor, that prevents the enzyme from breaking down the drug. So if I take an enzyme inhibitor that breaks down the drug, that means I have more drug available. More drug, exactly. Because I'm stopping the enzyme that breaks it in. I'm erasing the enzyme. So older drugs tend to cost less, but they have more side effects and are typically more effective. So an example of that is like Haldol, kind of jumping ahead a little bit, but Haldol's an old school drug. It's an antipsychotic, and it's really pretty effective, but it also has a ton of side effects. It's effective because it has a ton of side effects. It's like a bomb. So you can think like an old school nuclear weapon or like an atom bomb we dropped on like Japan, right? Boom. Very effective in terms of causing a lot of devastation. Versus like a sniper bullet that's like, well, it's really effective at, it's very specific, but it's not as effective at causing as much. Does that make sense? Like it's crude, and so it just does a whole lot of problems as opposed to something that's very targeted. So
you've mentioned like the drugs that have all the side effects, they hit all the receptors, so that's why they're good at what they do, because they hit the receptors they need to, but that's why there's all the side effects.
Exactly. And that's the pathology for. It's perfect.
There's like selective, non-selective, is that?
Yeah, exactly. Yeah. So we talk about like a drug that's selected for a particular like cardio selective. So like cardio selective beta blocker, which would be like metoprolol. You can get to an asthmatic because it's cardio selective. It's selected only for the for the beta 1 cells that are on the beta 1 receptors that are in the heart, but it leaves the 2 receptors in the lungs alone because it doesn't. Yeah, you get it. Awesome job. You didn't get a pen yet. There you go. Woo!
Thanks.
Absolutely. So Phenatonin. You won't see trade names on the NCLEX, but sometimes it's nice to have them. But I would always focus on the generic name like phenatonin or fluoxetine or whatever that might be, as opposed to NyQuil, or whatever. So Dilatin is the trade name for that. You won't see that on the NCLEX, so you need to know phenatonin, which is good because it's the generic name that follows all of the sonic rules. The pharmacology, like the trait name. It's the generic name follows all of the, did I say that right? Wait, I said it backwards. The generic name follows all of the suffixes, but the trait name can be whatever they want it to be, whatever sounds sexy. I don't know. They're like, what is that? It doesn't help you at all.
I have a question, so for the
Yeah.
exam, because I think I was so nervous that I didn't even notice. So should we memorize the generic brand?
Yes.
By itself, like that's what is on the text for base.
Yeah. You memorize the generics.
Okay, so like the other ones don't. It's like that's what confuses me. I'm trying to memorize both, but
Yeah.
so now just the generic.
Focus on the generic. She will always give you the generic and NCLEX will always give you the generic. And so the generic is going to be those things like, oh, here we go. Carbamazepine, that's the generic. It's so like, yeah, that's helpful if you can remember. I don't even remember that for the medications I take. Like I take metoprolol for my heart. I think that's Crestor, but I could be wrong. Yeah. What's it, Toprol, Topomax? It's Crestor, Rovastatin. I see I take them both, and I can't remember. So there you go. You're the one that has background as a farmer. Yeah. So this is here a wonderful resource. Your best friend. We had Leah in our crew who was a farm tech, and she ended up unfortunately breeding them. What? And so she ended up in the next cohort. I know, and so don't break your foot, but like if you're like, I don't get it, she knows far more than I do.
You give yourself some credit because I did not do well last time.
Okay. Well, maybe you're overthinking
I
We like questions.
think
for
I
ads.
it. Right? So here's let's talk about phenatonin, because this one will be on your exam. And one of the I'm pretty sure. So it's got a neurotherapeutic range. Why? Well, most of these have a neurotherapeutic range, right? She's like, you don't have to remember it, but that's what it is. It's teratogenic, but most of these medications are, right? Most of them are liver toxic. Gingival hyperplasia. So that is, think of the word gingivitis. You go to the dentist and they're like, you got gingivitis. So gingiva is your gums, and hyper means fast, right? Like hypersonic or hyper me in the morning after I take my Adderall, I'm hyper. Actually, it's supposed to be. And then plasia means to grow. Like neuroplasticity means to grow more cells, or and anti-neoplastic drugs means to drugs that stop the growth of cancer. These are all just those words, right? So when you add gingival hyperplasia together, it just basically means that your gums grow really fast. And so I had a brother-in-law who was on Dilatin, and his gums were on phenatonin, and his gums started to grow like, that looked like they were, you see receding gums. This is like the opposite. They're like almost growing over his teeth.
Is that
It is, yeah. Yeah, they cut down on his dose. Eventually he went off of it, but he was having a lot of seizures when he was a kid. He was adopted and was like, had his mom was smoking meth and was addicted to drugs and drinking a lot. So he was born with fetal alcohol syndrome and just a mess, but he was doing a lot of seizing when he was younger. And yeah, he's got some challenges, but like if you know sports, like he knows every sports statistic that's out there. It's like he's an okay reader. He's got a lot of learning disabilities, but he's like an idiot savant almost when it comes to remembering sports statistics. And I'm like, I totally need to take him with me to Vegas next, over 21, right? So it's a liver enzyme inducer. This will maybe a drug, a question. It's why some of these things I left in here, because I'm like, oh, that sounds like a good base question. Basically, just know it messes with your liver, and if it messes with your liver, it can decrease the metabolism of other drugs, and it's highly protein bound. So that's part of the reason why. Does that whole protein binding thing make a little bit of sense from the last time? Okay. All right. So the next one was carbamazepine, and you might look at this, the ending here is zipine or mezapine. That's the zpine is the suffix on that one. And this is primarily only for tonic, clonic, and partial seizures. So you can see this as, you'll see this for bipolar meds. And so you guys might have seen that as well, because it stops the hyperness in the brain, like the rapid cycling in the brain. And so that makes sense from a standpoint of a seizure medication. Pretty similar. Let's keep going down here. Maybe. All right. So with carbamazepine, these were two things that were important that I could see being a Bayes type question. The half-life decreases over time, which means that you have to increase the dose's frequency over time because it's getting like maybe the half-life was 5 hours and now it's every 4 hours you need to give it, and then it's every 3 hours you need to give it. That makes sense. The half-life is, it means you're excreting it more quickly. So you need to increase the dose or you need to increase the frequency. And then there's a number of meds that cause agranulocytosis in this particular category, these psych meds, which are kind of interesting. And so this is one, clozapine is an antipsychotic. We'll get there in a minute. But that's another one that you should know that can cause agranulocytosis. So agranulocytosis and pancytopenia are the same thing, basically. So a granulocyte is one of your cells that comes off like has, it's like a white blood cell that has the granules in it. And cytosis is this is a stupid word. I don't want to go too deep in it, but I'm going to share with you, but I don't want it to mess you up, but I'm going to share with you in case it messes you up, okay? So if something is cytosis, it usually means that there's more of it, but you see the letter A. So what's a good moral and abnormal or amoral means opposite of. So this is agranulocytosis means it's going to decrease as opposed to increase. It's the opposite. So that's why it equals pancytopenia. Any idea what that is? So pan means all or bread, depending on Spanish or Greek, right? So pan, cyto means cell, and penia means to increase something. And if you need a bad way of, means to decrease something, means to lower something. Pancytopenia means to decrease something. And so, I don't know, you can think of some little tiny guy's little penia, if that helps you, you know. It's like, is that a penis? No, it's a penia, you know, it's like, it's cute. I don't know, whatever helps you remember. And so sometimes the cruder the mnemonic, the better it sticks. My sister was a TA in college. God, a long time ago, 30 plus years ago. She told me, and she was teaching anatomy and zoology. I still remember some of the mnemonics she taught me back when she was a couple years older, because they were awful. I couldn't repeat them in mixed company, but I remember them, so they stick. So you can think of like penia means tiny. All right, so basically it means agranulocytosis means that they're gonna get sick because they don't have any white blood cells, because that count is down. They don't have any red blood cells because that count is down, and they don't have any platelets, all of them. So those are your three major ones, and pan means all three. That makes sense. 3 letters in pan, 3 major parts of your blood: white blood cells, red blood cells, and platelets. So they'll have you might hear neutropenia. If someone's on neutropenic precautions, what do you do with that? Any ideas? Remember from Bundy's? All right, someone's on neutropenic precautions. That means they probably have cancer or HIV, and so you're protecting them from you. So that's like you gown and you glove. It's because they're neutropenic, right? Or if you're on cancer and it totally takes out your white blood cells, you can get sick. You can get them sick. So that's neutropenia. Thrombocytopenia means that you don't have any thrombocytes, which means you can bleed out. And then anemia is, we don't suppose we could be like erythrocytopenia, but we just call it anemia. Low red blood cells. So you want to monitor if she asks like, okay, a patient is on, what medication were we talking about up here? Yeah. Oh, let's see where we go. Ooh, let's go this way. So we're at carbamazepine. So a patient is on carbamazepine. What lab should we be drawing on them periodically? Yeah, your CBC, right? Because we want to check for agranulocytosis. So you see how those pieces fit together? Okay, so that's a good example of like an NCLEX question. You see how like you had to know the drug and you had to know what the drug can cause, and then you had to know what to monitor. And that's that whole Bloom's taxonomy where you're like, okay, wait a second. That's why they're deeper and they're harder because you're applying more bits. And that's why I'm like start early on this stuff because you can't memorize all this. Your brain has to start making these connections because it's just it's harder to memorize that. So a little bit there. So we want to do that. So let's say a patient, let's look at this again. It can cause agranulocytosis. Let's change the question. Which of the following signs or symptoms should a patient that's on carbamazepine be instructed to look out for? And it might be like sore throat, right? Or a fever of over 101. Why? Because why would that be important for them to look at? What's that?
Low white cells lead to.
Low, one more time, really loud. Say with confidence. You were so correct. Got this.
Low white blood cells can lead to infection.
Low white blood cells can lead to infection. And so if you're seeing signs of infection, like a sore throat or like with that medication, so that's one of the things. So sore throat, fever, maybe they have maybe there's some extra bleeding that's happening, you know, like more so than just a little bit when they're brushing their teeth, you know. They might be like, they always like to ask a question like, who the hell uses a stiff bristled toothbrush? I don't even know if you buy them, but they're like, you know, to teach the client to use a soft bristled toothbrush if they're on, like, that's a medication that you would be, don't scrub your teeth over really hard because you don't have any platelets potentially and you can bleed out, right? So valproic acid is Depakote. It's pretty standard. And you can think of one way, valporate is the generic term for that. You might see it as valporic acid, you might see it as valporate. They're both the same. But you might think this one sounds like valporate sounds like a violent ape, doesn't it? Usually say some violent ape is like seizing around or whatever, bounding on things. Whatever helps you do, remember that. And you'll be like, oh, I remember Ben. He was doing that grand mal seizure violent ape thing, valporate. So that's a spastic ape, you know. You can also use valporate or valporic acid for bipolar. There's a lot of these questions, a lot of these drugs work for that. Also use it for migraine. It's teratogenic. It's less teratogenic than other medications, but it can cause neurotube defects. And so their suggestion is if you have to have a pregnant patient and they're on Depakote or valporate or valporic acid, then they can take a folic acid supplement, which helps prevent neurotube defects. So someone had a good question. They're like, what happens if you have a seizure disorder and they want to get pregnant? You're like, yeah, what happens? And so it's risk benefit. It's trying to find the lowest amount of dose, or maybe something like a valporate or some other medication that, or combinations of medications that are more protective of the fetus. And that's how they do that. So this was the one she wanted you to know about. Can cause pancreatitis. So I don't know how you might try to tie that in there, and maybe you're like, valporic acid, it's like it's acid. And if I get pour acid on my pancreas, it's gonna kill my pancreas. I don't know, right? It's gonna hurt like hell too, right? But and these would be If you have a patient on valproate, what's some education you might use? This is one of those NCLEX style questions is then you're like, oh, how about abdominal pain? Nausea, vomiting, anorexia, gnawing. This is the key here, gnawing epigastric pain. So if you hear gnawing epigastric pain in NCLEX world, that means pancreatitis. Just act that one. And so epi is above, right? Get your epidermis, get your, it's on top. Epi, and then gastric. So where's your epigastric region? Yeah, it's here, right? So above your stomach. Epi, above, gastric, stomach. So it's above your stomach. So if you have a epigastric, pancreatitis can cause things like ARDS and DIC, and you don't know any of that right now. You'll get that in med surge. So, but that's just a little bit about it. Are we doing okay so far? Oh, think valproate like violent ache. So, so you could think of a violent ache that's having a seizure.
Oh, okay, just to relate to the it's a seizure.
It's a seizure medication. Yeah. So if that helps you, or you can think about bipolar ache who's maybe really kind to you and then wants to rip your arms off because you can use it for bipolar too. So, yeah. And then, but no, and then maybe valproate, acid and pancreatitis. I don't know. What's a way you might be able to relate this? Pouring acid on your pancreas, is that okay? Yeah. Maybe something you might be able to remember. I don't know. It's kind of a weird stretch. All right. So we're gonna look at phenobarbital. We're gonna look at barbiturates in a little bit in a minute. Some more, but this is another medication. It's a barbiturate. These are some downers. They used to take these a lot in the 70s and people get high and die. Like they're downers, they're CNS depressants. What's that? It's a schedule 4. Oh, thanks. It's only a schedule 4. I believe you. All right. I know Adderall's a schedule 2. So I just assumed it was higher. Schedule 4. Thanks for correcting me. I appreciate that.
Sorry, I just thought.
No, and and if there's anything, again, if you guys have stuff, this is a sort of mutual exchange of information, right? I survived it, and so I'm helping to teach it, but that doesn't mean I know it so well. Does that make sense? Like, so, that's why you have an instructor. That's not me, who's actually had more farm classes than I have. So, newer charts, you have oxcarbazepine. Yeah, thank you. One more time. Carbazepine, thank you. Do you know if you ever want to, like, before you go into a patient's room and you're like, you got this medication, but God, I don't know what that is. You can go to Nursing Central and you can click on the medication and you push a button on there. It'll say it for you. So there you go. This is one, she said that this is another one that you should be aware of. It can cause hyponatremia, especially with diuretics. So where I've got these like little highlighted things, these might be potential test questions where I put them in red. Because she said those things. But you can note the suffix, it's a zipine or a zipine. It's a newer version of carbamazepine, which is fine. That one was throwing me a little too. But low sodium typically shows up with neurosymptoms when you see test questions for NCLEX. If they're like confused, they have a change in level of consciousness, or they're drowsy, or they're whatever, somnolent, which means drowsy. That if you see neurosymptoms, think neuro, Na, sodium, right? Neuro and sodium. If they've got arrhythmias and their heart's beating strangely, that's potassium in the NCLEX world. So potassium's heart, sodium is brain. And so if you start to see symptoms of like neurosymptoms, is this a sodium issue? It might be. And then if there's, can cause confusion. So low sodium, confusion, neuro issues. It's very teratogenic. I don't know. So then there's GABA. And that works on GABA in the nerves. It's most commonly used for nerve pain. It's well tolerated. And there's pre-GABA. You see the GABA in there again, pregabalin. It's also used for nerve pain, for fibromyalgia. She said that's in Schedule 5. I didn't.
It's not. Pregabalin is.
Pregabalin. It's like,
Pregabalin is not controlled in Colorado,
okay. So there you go.
which doesn't matter.
Yeah, you guys don't need to know that. But she said, I don't know why I wrote that down, but or left it in my notes. Maybe it was. But GABA. So GABA, do you guys know what GABA is? Okay. So I don't know. I've got this in here and I'm going to email this all to you guys, but okay, so we'll get back there in a second. Here we go. Down here, GABA inhibits the action of the central nervous system. So it makes you sleepy. So if you don't get enough GABA in your life, it'll lead to things like insomnia, stuff like that. So a lot of the medications that help treat insomnia increase the levels of GABA in your body. GABA is what they call an inhibitory hormone, or inhibitory neurotransmitter, but basically calms everything down in your brain. So a lot of your anxiolytics, which are anti-anxiety drugs, I'll go over that in a second, but they work by increasing GABA. Things that help you sleep increase GABA. So anything that makes you kind of tired or relaxed or calm pretty much increases GABA. So that's how that works. And so let's apply this to status epilepticus, which I remember your name, Stephen, like nailed with what happens what causes status epilepticus? Yeah.
Communication too quickly.
Yeah, going off your meds too quickly. Yeah, that can cause static epilepticus. So there are two reasons that can happen. Status epilepticus is a tonic-clonic seizure. She mentioned this and she spent a little time on it. So maybe it might be important. That lasts 5 to 30 minutes or more than one seizure in a 5-minute period. And so that's just somebody who's just seizing and seizing and seizing. And what's happening when I'm seizing like this to all of my ATP? Yeah, totally depleted, right? So what's that going to do to my ATP is going to be my cells are starving. And so now they need what to give more energy? Glucose. And so what's going to happen to my glucose if every cell in my body is craving it all at once? Yeah, it's going to totally crash into the toilet, right? So my patient is going to become and have low glucose, right? So I'm going to need to give them some more glucose. And I don't know I think we put the treatment down. Yeah, it's not here. So why do seizures happen? It's either too much glutamate, which excites the brain. Or not enough GABA, which can kind of help keep things sort of calm. So so you can either decrease the glutamate or increase the GABA. And one of the things I've mentioned in previous reviews, a lot of drugs in the body either increase something or they decrease something. And so it's a lot like if you've taking a shower and it's got two knobs on it, like it's an older shower, right? You've got hot water, you've got cold water, or the bath water, you're trying to get the bath water just right. So you can turn up the hot water or you can turn it down. If it's too hot, you want to turn it down, or you can turn up the cold water if it's too hot, right? Or you can turn down. Does that make sense? You adjust the temperature by either, if you want it warm, I need to have some hot and some cold, right? If I want warm water. Because the water that's coming out of the faucet's too hot. It's like 130 degrees. It'll burn your kid. But the water that's coming out of the faucet on the cold side is too cold. So I want to mix them. right? That's your brain. Your brain is, or your body's in homeostasis. It's balancing the hot and the cold. And so some drugs will either turn up the hot water, or it'll turn down the hot water, or it'll turn up the cold water, or it'll turn down the cold water. And that's pharmacology. It's all about turning up and down the right thermostat. And we have a lot of drugs that's basically what they do is they just turn up and down the thermostat. They make your body produce more or less of something. More hot water, more cold water, vice versa. So we can turn down the glutamate, or we can turn up the GABA to help calm the brain. So benzodiazepine turns up the GABA, and they're PAMs and LAMs. And one way that, so GABA increases the action of the inhibits the action of the central nervous system. So it makes you sleepy. It inhibits the action. And one way to think about that is Pam gets anxious when she goes on the lam. I don't know, like when you're running from the law, you're out on the lam. So now you're anxious about that. And so she needs a benzo to help with that. And we'll look at that in just a little bit more here. So this might be a test question. Treatment of status epilepticus. What's the most important thing if somebody's seizing? We want to maintain the airway the best we can. When they stop seizing and we can give them some IV glucose or something, we want to correct the hypoglycemia because they're going to be low blood sugar. And so we want to give them some dextrose, and we want to stop the seizure. So you want to give some glucose, in part because hypoglycemia can cause a seizure. Remember my friend who was, going to the grocery store to get him some lunch, and we didn't make it. He seized in the parking lot on the way in. So you want to give some lorazepam, note the suffix PAM, or you can give diazepam, which can be used rectally. She mentioned those two. But you see, just note that the F here, PAMs and LAM.
Ben, you said you're gonna email that to us.
Yeah. I know it's about that time. Do you guys want to keep going? Okay, we keep going. If you need to take off, you can too. So antipsychotics. We'll move over here and kind of go sort of psych drugs. They block your dopamine receptors. So they're if you block something, it's an antagonist. Hey, remember, and is that helpful? Good reminder. Anybody hung up on agonist versus antagonist? Because I can review those. You guys got them okay? Okay. So you can think of an agonist as whatever you're supposed to be doing. And you can think of an antagonist in the story as always the bad guy that stops the protagonist from doing whatever. Aha, I am the antagonist. I see that you are, I'm going to stop you. That's the antagonist. Or you can think of your younger brother who used to antagonize you, right? It stops you from doing. So if you want to block dopamine and we over-educate them, you get Parkinson's disease. All antipsychotics block dopamine in some way. So what happened? Okay, so Parkinson's, does that mean I have too much dopamine or too little dopamine? Too little dopamine. So how do I correct that? What's that? How do I correct? Don't go. I can see decrease in acetylcholine because my acetylcholines are, and I can drop it down by using something like anticholinesterase or like an anticolon reducer. Yeah, so I can, those sort of things. So all antipsychotics block dopamine. First gen, it's like haloperidol. It's effective, but there's more side effects. Second generation is like a riprazole, which is Abilify, if I recall. And that's a pretty effective medication to but that's second generation. And we'll take a look at that again here. First and second. Typicals tend to block D2 receptors and they cause EPS. So more EPS. You guys remember what EPS is? That's gonna be like the Parkinson shuffle. There's a little video that if you watch last week's, I showed the video during last week and it's on there, and the link is also, I emailed the link to you guys too. And it's got some really good, it's a really good video on antipsychotic drugs and what they do. Second generation, they have a they have a stronger lock or block of serotonin. They have a weaker affinity for D2. They're more like D6, I think. But Abilify is an example of that. So some side effects. They'll cause sexual side effects. They'll cause some anticholinergic side effects, like dry mouth, induced Parkinson's. So why do they cause hypotension? Yeah, it dilates the blood vessel. Dopamine is one of those drugs that contracts blood vessels, right? We give that to help with low blood pressure. If we but if we block the dopamine, we're going to potentially cause hypertension. See how these systems start working together? And like, oh crap, but we're trying to block the dopamine in the brain to get rid of schizophrenia, but now we got to worry about them passing out from hypotension. Like, damn, okay. So you can see how we start getting these effects going on. So EPS, so that's a pseudo-Parkinsonism and things like that. And it's basically if you over-medicate your psych patient, you can make them look like they've got EPS. And so this is the video. I'll email this to you guys again, but watch this. It's a pretty good video. He goes and he talks about antipsychotics, but he also demonstrates what these look like: akathisia, tardive dyskinesia, acute dystonia. And so when I see it, I can remember. So tardive dyskinesia can be permanent. She mentioned that. The tardive dyskinesia looks like this. If we might have seen somebody at the store and at the Walmart, goes probably ice cream for bread. We might have been on a haloperidol and we picked like a goat. Sometime I just hungry and it looks like they're chewing tar. So I do with their tardive dyskinesia from water tar, or they'll do this with their tongue a lot. So their tongue will poke out of the side of my same thing. And it can happen if it's as simple as one dose and it can be permanent. So it's weird. So don't do drugs, okay? Mr. Mackey. All right. So if they're overdosing on and have EPS, you can use benstropine, matidine, benzodiazepines, or diphenhydramine. And a lot of what we're doing here is we're blocking, we're re-regulating that acetylcholine level by if we give too much dopamine blocking drug. Do you want me to walk you through this one? Okay, so if you're giving too much dopamine blocking blood by having drug, so it's easy to see. We're going to talk about relativity. So we have dopamine levels. Maybe not. So they see it, right? Acetylcholine. So if I'm doing giving someone a dopamine blocking medication, what's going to happen to their level? Let's say this is basal. What happens if I give someone an antipsychotic to their dopamine? Yeah. What do you think it's going to do to dopamine? It's gonna go down. Yeah, you guys think so? Yeah, you're right. So if I do an antipsychotic, we're gonna push the levels of dopamine down, right? What's happening to the level of acetylcholine? Has it changed? No, it's still up here. So its level is here. But what happens? It's still at baseline because we haven't given a medication that affects the acetylcholine, right? We've only dropped the dopamine. But what's it looking like relatively? If this is the new level of dopamine. But it needs to be what would happen? See, yeah, the acetylcholine's high, isn't it, in comparison? So what happens? So now we start getting symptoms of having too high of acetylcholine, which is where you're getting Parkinson's, right? Because Parkinson's is the same as too little dopamine and too much acetylcholine, right? That looks like Parkinson's. Does that make sense? Cool. So Benadryl is an anticholinergic. So is amantadine and benztropine and dantrolene. And so that's going to decrease the acetylcholine and bring it back down here. And so these levels, even though now they're both low, right? Step 10. Does that make sense how that works out? Okay. You guys just learned some pretty cool Phram. So you have dopamine is too high. If I'm a schizophrenic, my dopamine is going to be too high. I'm going to take a medication which reduces my dopamine. That's what all antipsychotics do. Hopefully, I give them the right level of a dose where I don't affect the difference here that causes symptoms with acetylcholine. But I might, and that's when you start to see Parkinson's-like symptoms, things like that, or drooling or things like that, because this is your acetylcholine is your rest and digest. Is that connected for you guys a little bit? Make a little more sense? I'll bring, I should remember to bring some pens next time. So, haloperidol, old school med, drops the dopamine pretty quick, but it's going to have higher levels of EPS. Second generations, there's lower levels of EPS. And they're equally effective, but the reason for that is first generations target dopamine. Second generations target a different receptor for dopamine. They also help block serotonin. So they work in a different way, which is why you get a different kind of symptom. So you get lower levels of EPS, but what you tend to get is higher levels of weight gain. And so that's the primary teaching behind second generations, is that people tend to get fat taking second generation antipsychotics, and the two are clozapine and olanzapine. You can look at the suffix, so you can see the zapine here. But one of the ways to look at it is these. You see, they're almost the same drug. Spelling, right? But you can think of the big O, olanzapine, like just like a fat donut or a fat guy with like a little head, it's like arms because he's really fat. He's like, oh, look how big he is. But olanzapine is really well known for causing diabetes and dyslipidemia and some others. And clozapine will, I think I have this down a little bit later, but schizophrenia, too much dopamine, too much dope causes you to see stuff that isn't there, right? Dude, this guy's awesome, right? Too much dope. Gotta cut down on the dope, man. This is some good shit. So too much dope causes you to see stuff that isn't there. Too much dope, can cause you to hallucinate, like a schizophrenic. Why you can sometimes give a Parkinson's patient, you give them too much levodopa, they can hallucinate. you start to treat that, they start to have changes in their behavior. They start acting a little cray-cray, right? It's one of the side effects of some of those medications is that personality. Well, you just gave them schizophrenia. You see how we can see what happens when we do that, right? So if you give too many antipsychotics to a Parkinson's patient, they'll have EPS. But if you give too much levodopa or dopamine to a Parkinson's patient, they'll start acting like they're schizophrenic. See how they're opposites? Crazy, isn't it? You guys get that all right? Yeah? Okay, cool. Because once you guys start getting these things, you'll be like, oh my God, this happens all the time. You're like, okay, too little acetylcholine? Not enough, too little acetylcholine, I get Alzheimer's. Too much acetylcholine, I have Parkinson's. Too much dopamine, I have schizophrenia. You know, a lot of these mental drugs are just too little or too much. So three objectives for treatment: stop acute seizures, prevent future seizures, promote adherence. So this is oftentimes you'll see this: encourage family members to assist with medication, or there should be written instructions, help them stay on schedule. Don't stop them suddenly. This happens to a lot of our homeless people. So you get that. Clozapine cause is agranulocytosis. There's another medication we just talked about that does that, right? I can't remember which one it was. I think that's right. Is that right?
Yeah, that's mine.
Yeah, yeah, great. So another one of those helpful study strategies is to like do a little bit, like you're reviewing, and then just ask yourself what you just learned. That chance of going back and doing that immediate recall builds a neural connection. Memory is all about increasing the number of dendritic spines and connections between their cells. So that's how it works. So clozapine blocks dopamine, causes weight gain, but it's also causes problems with the rest and digest. So it's not likely to cause EPS. You would do lower doses with older patients. Older patients probably shouldn't be on antipsychotics for the most part, especially first generation ones. But anyway, risk of agranulocytosis. This is a super common test question. So just FYI, I don't know if it'll be on this one, but you'll see it. So you'll want to watch for fevers and sore throats with low BCs or fatigue or anemia. These are all signs of symptoms of those low blood sugar. The way I remember this, if you have like red cells and white cells, so you think about red clothes and white clothes. What happens if you wash your red clothes and your white clothes together? They turn pink, right? You've ruined your clothes, right? So I think about my closet, a pine closet, and my closet peen. And so if I have my red clothes and my white clothes and I put them together, I got to keep an eye on my reds and whites. If I might be in my clothes in my closet, right? I got to keep an eye on that. So I don't mix them together inadvertently. Well, I got to keep an eye on my red cells and my white cells when it comes to clozapine. Does that help a little as a way of remembering agranulocytosis? So those are the ones you got to watch mostly. So clozapine, watch your red and your white blood cells or clothes with clozapine or pine closet. All right, let's go into depression. Loss of pleasure in nearly all activities. That's called anhedonia, if you wanted to know that. Loss of motivation, grief, sadness, likely insufficient. I wrote this word in here so you guys would remember. Monoamine transmitters, norepinephrine and serotonin. So your monoamines include dopamine, norepinephrine, serotonin, and epinephrine, and norepinephrine, serotonin, and dopamine. So if we have too little norepinephrine and serotonin, what do? We pump that crap up, right? So we can do that with any of these medications. And we're doing okay time-wise. If you get me to take off, it's fine, but I can screw it a little. So 5 main classes, SSRIs. Anybody remember what that stands for? I thought I heard you say that. Hang on. So I got two more here. I forgot I had them in my pocket. So yeah, selective serotonin. What about SNRI? Nice. But I already gave you a pen. All right, atypical antidepressant. So an example, this one's bupropion. She likes bupropion. Bupropion's a good one for, it's an NDRI for the most part. Norepinephrine, dopamine reuptake inhibitor, if I remember right, that's its. Does that sound right? NDRI, do you remember? Okay. So it's good for off-label use for ADD. Also used for anti-smoking, often used for like helping people like get, lose weight. Tricyclic antidepressants and monoamine oxidase inhibitors. And what do we know? We'll get this, but what do you know about this word right here? ACE, yeah. So that makes it an enzyme, right? Cool. And what happens when we inhibit an enzyme? It does. It helps the medication last longer. So, do you remember MAO? This is an MAOI. Do you remember MAOB? Okay, so we were hearing about that in the last week or two. The monoamine oxidase B inhibitor. Do you remember what that one's for? The what?
The brain.
It is, yeah, it is, right? What medication, what disease it is? Alright, MAOB helps to break down. It's that MAOB, so monoamine oxidase. That enzyme breaks down dopamine. What would I want to be concerned about with low dose? Who said that? That's totally right. Parkinson's, yeah. Because it breaks down MAOI and MAOB both break down dopamine. And so we want to be cautious. So we use that for increasing. And so when we use, I'm sorry, MAO, monoamine oxidase, monoamine oxidase breaks down monoamines. Does that make sense? So monoamine, that's going to be like serotonin, norepinephrine, dopamine, all those monoamines. And then oxidase, this is an enzyme which oxidizes monoamines. So this means it breaks down monoamine. So it means it's going to reduce those things. But if I inhibit the destruction of that, then I'm going to increase the amount of dopamine. So these things increase dopamine, they increase serotonin, they increase norepinephrine. This is how your body gets rid of the extra crap. It gets rid of the extra stuff. It uses monoamine oxidase to destroy it. But if I inhibit that enzyme, did I just confuse you all, or is it okay? You guys got it okay? Yeah, all right, good. It's one of those things like it's like a double negative, right? Okay. So initial response 1 to 3 weeks, maximum response 6 to 12. So this might be what's a test question you might see with this one? Could be like, my son went on Prozac last week and he's not feeling any better. Well, what would you tell him? Yeah, it takes a little bit more time than that. Exactly, that's right. If you're doing some teaching to some parents and they're putting their teen or young adult on there, it can increase your suicide risk, especially like for the first month or two, couple months. So she mentioned this, so she might have a test question that's related to it. One of the things, the tricks that providers will do, so write a small script. They're like, here's the script for 7 days. I'm going to see you next week. Why are they doing that? It's so that you'll come back in 7 days and they can check and see how you're doing. And they can check your suicidal ideation score. They can make sure that you're on the right track. So they might do 1 or 2 weeks because they want you to have an appointment on the calendar so that they can reassess you. And if you're having a really shitty time and you're feeling suicidal, you'll tell them. So they can be like, oh, okay, let's not have you off yourself. But if I write it for a full month or 90 days, and I don't see them, they could go commit suicide, right? Yeah, so they don't overdose on a drug and try to label the things. Absolutely. So you want to discontinue those drugs slowly. So, serotonin syndrome, SES. This is usually if two drugs are increasing the serotonin. Sorry, that's so there's like SNRIs, some of the things that she had thrown out, some that you might want to be aware of. Ondansetron, which is Zofran. It's an antiemetic which can increase serotonin. And so that's given alongside like Prozac or something like that. You can increase the risk of a serotonin syndrome. That makes sense because you're giving more medications that are increasing serotonin. It's like giving too many medications that increase CNS depression. If you give a benzo and you give morphine and the person starts drinking, they'll really shut down their respiratory tract because they're just ODing. Another thing you'll see, St. John's wort. Oh, it's always a bad idea in the NCLEX world to take this because it's effective as an antidepressant. But because it's effective as an antidepressant herbal supplement, we want to tell people not to take it because it's not regulated. And if you take it with other crap, you can OD on that other crap. So the best advice is just to tell people not to take it. Some naturopathic doctors might prescribe it, but they should be taking it with the knowledge of the provider. So if you see confusion, anxiety, restlessness, hypertension, tremors, hypertension is a big one. Selective serotonin or serotonin syndrome is basically a hypertensive crisis. We've amped up all of basically the dopamine, the norepinephrine, the serotonin, they're just all high. And so their blood pressure is high. That's what's going on. So she's got some other meds in here. These are all from her thing that caused them. She mentioned nutmeg, ginseng, St. John wort, ecstasy, nutmeg. Let's take a look at these. They're okay. SSRIs, we talked about those, selective serotonin. Paxiltine, she mentioned this, more weight gain, think fat parrot. Paroxetine, which is Paxil. So you can notice the ending here, oxetine, xetine, Phram. You see this ES in these, so this is the same escitalopram and citalopram. These are the same medication. This is just a side thing. You don't have to notice it all, but if you see ES, they're the same medication. This is just a mirror image in how the actual molecule is laid out. Like if you were to take a molecule, like turn it 180 degrees, that's where you see this ES. So they're basically the same medication. Oftentimes have similar symptoms. Usually the ES tends to be a slightly newer version of the drug. They're like, oh, okay, well, we had Celexa, we had that for 8 years, and oh crap, our patent's running out, so we can't make people pay more for that. Let's just flip it over. Oh, look, now we got a new patent for another 8 years. So, friendly little drug thing, just how to make money. So you can look at etine or etune. You got this. You can like a fluoxetine. You can think of it. Etine helps keep my depression in tune, or I don't know, or maybe you can see like whatever helps there. Just to help you remember, that's an antidepressant. Phram. A pram is an old word for a baby buggy, and so sometimes you're pushing a pram, and you're like, "Oh, this makes me happy." I got the old pram. This makes me happy for my baby. No, old prams are going to remind you that those are selective serotonin reuptake inhibitors, and it'll make you happy. You push the pram around. All right, I don't know, but that's an old word for that. This is probably a teaching point to remember. A lot of antidepressants cause sexual side effects, and that's why people stop taking them. So they cause feelings like impotence or erectile dysfunction, or you're just not in a mood, which is really weird because before maybe you were depressed and you wanted to have sex. I don't know, but just something interesting. Here's another another. There's just the Xtine again here, oxetine, faxetine. These are just if you need to try to remember those endings. You don't probably need to get that specific with these. I would just know in general what an SSRI is and the teaching points. I would know that they can cause sexual side effects. They can cause weight gain. They can cause depression. That those sort of things I'd focus on the SSRIs. Those are the most important things. An atypical antidepressant, bupropion. Might just review this one quickly. It decreases sexual dysfunction, smoking, seasonal affective disorder. She's got some of these are the ones she mentioned. Trazodone, this is often used as a sleep aid. I took it for a sleep aid for a while. It increases QTC, prolongs QTC length in your heart, which can cause palpitations. And since I'm a heart patient, I started getting these weird palpitations. I don't think it was related to the trazodone, but they're like, no more of that for you. Okay, tricyclic antidepressants are old. She said if you see one on a test, it's going to end in tryptine or tryptamine. So one way you can think about it is the word tri for tricyclic and the word trip, which is tryptamine. And so you say tricyclics, give me a happy trip, maybe. And so if you see the word tri and trip in there, you can think there's a lot of side effects and cause. She says they can block alpha-1 receptors and cause hypotension. I don't doubt that because if they're, I don't know why, but that's good. So here's let's take a look at MAOIs. Take just one more time here. So here you got the ending ACE, which is an enzyme that breaks down something, and so the ACE is going to break down monoamines. And so what are monoamines? So sort of serotonin, norepinephrine, dopamine. So so where are MAOBs used? We use them for treating Parkinson's. Remember that? Because and why do MAOIs and MAOBs, why do we use them? Because they increase more dopamine, so that can help with depression and Parkinson's. And they can also, MAOIs are more selective for serotonin and norepinephrine, which is also good for depression. MAOB is more selective for dopamine. So that's why they use it. There's no, almost done here, guys. So that's pretty good. This would be the teaching for MAOBs is no triaramine rich foods, because that'll cause a hypertensive crisis that's like serotonin syndrome. So no aged cheese or wine or sausage or chocolate or beer. Basically, life sucks. So if you got to go on MAOB, I think that's why suicide impression goes up, because you just no more drinking, no more cheese, no more chocolate. I mentioned this on Wednesday, but triaramine, does anybody remember what triaramine is? What it is? Why? Okay, so triaramine is an amino acid. And it's an amino acid precursor to, or a chemical precursor to dopamine and to your other monoamines. And so triaramine is found in a lot of foods. And if you basically have more of the raw product, you can increase the dopamine downstream, if that makes sense. And so we want to reduce the amount of triaramine that's available, because we no longer, if we're taking an MAOB or an MAOI, we're breaking down, this is the enzyme that breaks down too much mono. It's how our body gets rid of the extra monoamines. It uses monoamine oxidase to do it. It's the thing that vacuums up the extra monoamines. We're stopping that process to treat depression. But if we stop that process and then eat food that increases the monoamines, we end up with too much monoamine. Does that make sense? So like if I'm eating too many more, I'm basically eating monoamines. And if I get rid of monoamine oxidase, by stopping the monoamine oxidase, I'm going to OD on my monoamines. And that's why you can have more. I mean, it's basically an amino acid. So basically, never take St. John's wort. Bipolar 1 and 2. We're about finishing up here. It's a mood stabilizer. Lithium. It's a mood stabilizer. Oops. Yeah. So you can use an antipsychotic or an antidepressant for bipolar. Where else do you see bipolar medications? We talked about this a little earlier. You said it. I think you said it. Epilepsy. So yeah, you see it with epilepsy. Okay, well, so the drug of choice is for that is going to be a mood stabilizer, and so they might mix in an antidepressant or an antipsychotic. But one of the most common mood stabilizers is lithium. And what do you remember about lithium? It's that. Something to do with sodium.
What?
Yep. Yeah, you gotta get your blood tested. So I don't know if there's any, I don't think there's anything left in this thing. So if you remember, no, it's totally dead. That's unfortunate. Do you remember the periodic table of elements? Little vaguely? Okay, so I think the first one is like hydrogen, it's like 1, and then like you have lithium, it's like number 3. Then you have sodium, and then you have potassium, and they're all stacked on top of each other. And that's because they all have 1 electron in their shell. And this is going really deep, but then you'll make sense. So lithium, sodium, potassium, they all have 1 electron in your shell. Your brain and your body are pretty damn smart, but it doesn't know the difference between lithium and sodium very well, or potassium, because they're all the same. And so you will start seeing medications that will impact lithium, potassium, and sodium levels. And your body will start to retain some of these things. And so you'll get a couple of those on Friday. I think we'll start to talk. I think you guys get spirulactone, which is a potassium sparing medication diuretic. And it doesn't, and so that's just kind of file that away, get that little piece of. But the problem is, your brain, your body doesn't know, and your kidneys, it's really your kidneys that don't know the difference between lithium and sodium. It can read that there's like 1, I don't know how it does it. Really cool. But it can read that there's like 1, it's positively charged with 1 charge. So it does this thing where it's like, oh, if your sodium is low, it's going to hang on to everything that's got 1 electron in its outer shell. Does that make sense? It's like, I am freaking out here. I don't have enough sodium. So anything that's got 1 electron in my shell, I'm hanging on to. Well, it's going to hang on to lithium, as well as sodium, as well as potassium. But look at how little that range is, that therapeutic range is with lithium. So if it holds on to just a little bit of lithium, it can become toxic because lithium is not, isn't that crazy? That's how that medication works. And that's how your kidneys work. So it's toxic with low sodium because the body doesn't know the difference. And so when you start seeing lithium toxicity, it's going to be like vomiting, diarrhea, sweating. These are good signs and symptoms. Remember, you'll see this on a test question. Maybe not for this exam, but you'll see it somewhere. And so the way I remember that is to think that bipolar sucks. It sucks to be bipolar. It's a hard disease to have. So you let them eat their damn McDonald's. Let them have their French fries. Let them have their Big Macs. They're cram full of sodium, aren't they? That stuff is crap for your heart. But what does it do? It keeps your sodium levels high, and that'll prevent you from having lithium problems. Your body won't retain lithium as long as your sodium levels are sufficient. The other thing lithium does is it makes you thirsty as all out. So people will drink a lot of water, which means they're dehydrating themselves and they're washing out all their sodium. So they need to be eating those fries. Maybe they should get a medical order for a large fry every day. The bipolar sucks, so the problem is with sodium. So that's why sodium. So know the signs and symptoms could be like altered manner stances, nystagmus, that unsteady gait, nausea, vomiting, and that's it. That's all I got for you guys, I think. Oh, GABA. Oh, we forgot about these. So if you can't sleep, probably don't have enough GABA. We already talked about these a little bit. Anxiety causes the release of cortisol. Where does that come from? Cortisol. What's that? The adrenal glands. Where are your adrenal glands? Up your kidneys. Yeah, they're little hats on your kidneys. Really cute. So they release catecholamines. So epinephrine and norepinephrine. Anybody struggle with that term, catecholamine, and remembering that that's like epi and norepi? Okay, what do catecholamines do? Anybody remember? What's that? Well, it depends on where they're at. So, and what it is. So catecholamines, what's part of your, yeah, it's sympathetic nervous system. It releases that can use to utilize this again. So, and so remember, it's the fight or flight. And so that's the way you can remember this is, any of you guys watch Indiana Jones and the Last Crusade? Yeah, they're in Venice. They're in the catacombs underneath the church. And what's down there? A bunch of like King Richard's tomb and a bunch of rats, and there's fire and there's bones. And is it scary? Yeah. Do you know what catacombs are? Catacombs are buried cemeteries. I mean, like Paris, Venice. They're in the catacombs. Are catacombs scary? Yeah, they increase your they increase your fight or flight, don't they? At least so you can run away from all those rats. So anxiolytics break up anxiety. Sedative hypnotics. Anxiolytic anxiety. Anxiolytic means to bust something. Lysis, like cell lysis. That's what that means. So an anxiolytic, so it's basically a cell lyser. Fun fact. Hypnos was the Greek god of sleep. Morpheus was morphine. Was the his son, and he's the god of dreams. Remember Morpheus from the Matrix? Yeah, it's an interesting. He's the god of dreams. There you go. And Thanos and Hypnos were brothers, and Thanos is the god of death. Just I don't know. I always think that's kind of fun. But barbiturates. Barbits are downers, so you can think you go to a bar for a bit if you're downer. You want to get drunk. That's a CNS depressant. I don't know if that helps at all. They're potent drugs and not used very often. High respiratory depression, fatal overdose. That's the death with dignity. Phenobarbital, one that's a common one. Benzodiazepines. And where do we use phenobarbital? We talked about it earlier. Anybody remember? Yeah, it's an anti-epileptic. It's for seizures. Good job. I'm sorry, what? Yeah, exactly. It's used for assisted suicide. Absolutely.
Thousand specifically.
I think, yeah, that I think you can use I think you can probably use pretty much any barbiturate if you take a high enough dose. It's like taking too much fentanyl. A lot of this in sort of respiratory CNS depression. Benzos increase your GABA, and GABA slows things down in your brain. So that's going to be your first choice for stopping seizures. So you might use like Atipan or lorazepam, if that makes sense. Benzos are okay, but they're not great for long term. So those are like diazepam, lorazepam. See the Pams and lambs? And Pam is on the lamb. And so she's anxious about being caught, so she needs to be on Ativan. You make a joke if you want to, whatever helps you guys. This may be a test question. I've seen it before. Flamazanil is it's the antidote for a benzodiazepine overdose. It antagonizes GABA. So if you give your patient too much, yeah, maybe you give them too much diazepam and they're just now they're tanking, you can give them flumazenil and it reverses that. Does that make sense? It's a good thing to remember. Just remember that one. I don't have a fun, anybody got a mnemonic for that one? Like flu, maybe, maybe if you make your patient sick with too many benzos, you can give them, I don't know, Flumas, I don't know. I don't know. I try to think up these things sometimes. Benzodiazepines are for sleep. We're almost done. So we have like Ambien, Sonata, Lunesta. So there's the, remember I said the ES is basically the same drug, it's just backwards. So you got the clone. And but these all start basically with Z's. So if you see a Z on your test, it's probably a sleep drug. Oh, it's most of the time. So, Buspirone, Buspar is a good one for anxiety. If anybody has test anxiety, they might try taking some Buspirone. You're supposed to take it routinely, but sometimes people take it purine. And then finally, amphetamines. You guys feel okay on amphetamines, or do you want me to hit them real fast? All right. Amphetamine, you may think about getting amped up. They increase your norepinephrine, dopamine, and serotonin. Methylphenidate, oops, that's misspelled. You might see the phen in there. Methylxanthines, I don't know how deep she's going to need you to go with all this. Probably not super deep. The thing I would look at more is the teaching on these, that you would give a medication. But chocolate and caffeine are also xanthines, so that's kind of a fun thing to know. And that's why chocolate makes you happy. So the thing about education for parents is that, especially in kids, like you get a little hyperactive little 8-year-old and you stick them on Adderall, they can really impact their level of growth. So I had a friend of mine whose son was really hyperactive. They put him on a pretty high dose of Ritalin. He was adopted, but he was from Thailand, and so he was like 5 feet tall, and some of that was probably because he was on so much Ritalin. Or not saying that's a bad drug, but he was also from a different culture that's a lot shorter. But so he was small in stature as it was, but there's that. There's non-stimulant meds, NDRIs. There's a black box warning for amoxicillin for suicidal ideation as well as personality changes. I was on amoxicillin for a while. My wife was sitting in her class. She was like, "Oh, black box warning for personality changes." I was feeling kind of pissed off for a while. And she was like, "I think you should." She's like, "You're never upset when we're on vacation, but you're always getting frustrated when we come back. Is it that you hate your job, or is it because that your amoxicillin is making you pissy?" She was right. It was the amoxicillin. So I went back on the Adderall. So little story there that maybe that'll help you guys. And then the last little couple drugs here and we're done. Are guanfacine and clonidine. They're alpha-2 agonists, but they somehow work by their alpha-2 agonists to increase norepinephrine, but they somehow work to reduce ADD but make you sleepy at the same time. I'm not exactly sure the wizardry behind that particular medication, but there you go. Any other questions you guys have? I'm sorry it took a little while, but I wanted to give you guys time to kind of go through all that. So, finish that. But you guys can always stay confident. Well, they're still here. They must have stopped. Any other questions? Are you getting things okay? Ish. Okay, just reviewing. Remember, you can always do one-on-ones with us, which I actually really. You can make that. That's what you want to do.
Sure.
If you guys need to get a pen, I want a pen, big box of pens, maybe that. It's a little bit of like.
Oh, yeah. Thank you.
Just take it easy, good luck.
What we've seen. Yeah, this one's not. Or, yeah. Well, no, she's, yeah, well, she's. But now when I told you, I said, actually, I told you that now. So I got to.
We got much.
Yeah. That's the actual.
Like building it.
There's no picture.
Yeah, so like, that was my, I was thinking back in. So they said to do, but she's bringing us to me.
They're supposed to be like a little thing to use in Blackboard, like a little.
I think there's,
It's public.
I wanna say. We're discussing minutes. I don't know, they might just take this as cheaper. But the reason they want to say this, because
Okay. And then for tomorrow, because you know how we're gonna have to pay your rating for that.
even like it's stuff. I don't know, but they did say this.
That's yours.
Yeah.
I thought it was.
It's accommodations.
Okay.
They're saying. Right, or
Yeah.
it's on that, building
Are you talking about like?
next to the wellness. Yeah, next to the wellness center,
Okay.
right? That's where we go for.
You can start there. Yeah, that's actually a good question.
I,
think they're looking at
Yeah.
Okay. So there, don't check the syllabus, it'll say in there, but the,
So what I was told to do, person connected me to Maria Lopez. She's like the referral person. She'll refer you to, they can get you a diagnosis for anxiety. Typically, all of that, but you can order to get like the same conditions and have a diagnosis.
Okay, well, she's gonna, yeah, thank you.
yeah, exactly, so there's that, and that's the same process, and you may need to talk to, which I think it's Marcus for me, but.
Yeah, he's another one that should be. Should be. If you talk like person, should.
That's but, she said that it's like fairly.
It is.
You just have to have that, like you have to meet any parents here,
Oh,
and then they can bring to the day, but it's.
I guess I mentioned I was treated for eating, I got accommodations, I didn't use them, but I went through the process to get them, so I could use them if I needed to. And so I thought then, so I took had my provider write a letter,
Right.
and then I took that letter to Mark Disabilities Office, which is Marcus Dan is. And then he sent an email to my professors and basically said, hey, Ben needs this.
I can.
And then,
Yes.
and then I kind of set things, if I wanted to, then I set it up. Testing center, but I didn't. But totally do it if you think you need it,
Yeah.
because like your classmates don't care, it's not a shame.
Yeah, I know, it's not care about the emails.
Yes. It's really good.
Yeah.
Yeah, you wanna, yeah. It's not my fault. This one.
So. It's a big line.
Thanks. But she said, the one percent. Yes. Go in and
The doctor.
like, yeah, like you're also in there, it's there. Maybe six.
Where do you have the teachers?
Or black.
Yeah, I did such a.
Because like, yeah, I was thinking of that, but it's not necessarily our interest. Well, I think I'm kind of.
It's just that he's saying.
Like things like that, yeah.
He's quite sad.
We're making it super easy. And you have to, it's gonna be on the second floor.
You know where that is, you know, his dance.
I'll sit down soon.
Yeah, it's downstairs.
Oh,
that office was like, why not?
all right, maybe they, okay.
Yeah, that's where I actually born.
Oh, maybe that's the right place. It might have been. I might have had this configuration. They changed office. They used to be here on
So.
and then they moved up there and maybe they.
I don't know, because sometimes I think I'll study too much and come soon. That's a question. I like the way you said that to be some of it, yeah, it was like, talk about dopamine, it's
Yeah.
not too much though, you know,
Yeah.
like too much though, you get high on the dopamine, that's something. Yeah, and another thing is this thing you talked about, I'll have in my content.
Present a good example. It's most commonly drug to treat someone with sleep disorders.
So, it would be something like this. Yeah, CNS. So the patient has to the section that's very emotional. Should also, should. That's the part, if you're where you got feel about it or that's a good matter. But, control. So if you're doing something to control it, will you do the immediate or short?
I would think if your seizure disorder is prescribed and controlled, I do probably want something longer acting, but I could be wrong. But that's why you're gonna look at the question.
So where did they have some guys that I?
They have a borrow. So it's on the shelf over there, and you can buy it on it.
And where do you borrow it to? From the.
It's it's just on the shelf.
With the, I'll take pictures.
Yeah, it's just on the shelf over there. Let's see what that question is. Number 2. What is the question?
Yes,
Oh, it's on. Long. Okay.
that's what you say.
Yeah.
Okay, so why not acting because diagnosis seizure disorder?
Probably so that it,
Oh, diagnose, okay.
yeah, they're diagnosed, they're not having.
Okay, you see what I thought they having a seizure, so you gotta act fast.
Yeah.
But
and
it's diagnosed.
Exactly, they're diagnosed and we want to control it, not stop it, but just like, okay, we don't have, so we'll give them photos long term. Since you didn't talk about a spinal headache, I don't know about that.
But if I wanted to try, it would be like, can you do A?
Yeah, it's
Because for
like
me,
all
for
the-
P, right?
Yeah,
No, you can't ambulate the patient. Oh, no, because it's fine that. First patient is sleep planning, yes, B. Okay. And let's talk about this. Yeah, let's see this. I think this will be, I'll take A, I'll take C.
everything with that.
And maybe even ASC is a show.
These don't have action, but it's definitely worth looking at because it's a free resource. It's taking up
18.
30,000.
Yeah, 30, right? And it's after 8.
Yeah,
What did I miss?
maintaining the patient.
Yes, I took planning, and I took the morphine. Is morphine part of it?
It's just a CNG.
Oh, and then I'm wrong with the morphine for H. So I took A, C, and D. So A was wrong.
Maybe it's doing the CNG.
You talked about this
I did that say,
antidote. That's what you talk about antidote, right?
yeah, it's an antidote for the.
Yeah, it's started by. That's the antidote for, okay, so the patient is. Other. So let's probably make the theory from major and surgery based on able to sleep. So the person cannot sleep, right? Or she cannot sleep. So this is an antidote you cannot use it.
It's an antidote for taking too many benzodiazepines.
Okay, and pencils are the pen and let's talk about,
Yeah, so that's the antidote for the PAMs.
okay. Let me take some pictures.
Sure.
Maybe I can get study.
But let's see, I did mention this one was 100 lists,
Yeah,
which, for which medications usually help you sleep.
is it a thing about it all?
It-
Because we didn't look at these.
We did, but it's interesting.
Oh, we didn't look at.
But
Let me stop this real fast because it's still recording.
Oh, okay.